Thank you very much for that, Dr. Bowling. I want to echo advocacy is a huge thing that we can be involved with. And a lot of times we go outside of our comfort zones when we start talking about policy and going to Frankfurt. Fortunately, I had a pretty good experience to be able to do that with our next speaker, Dr. Stephen Gillapsy. I actually went with him to the Capitol in Oklahoma City and watched him work his magic when it came to advocating. It is something that we have to kind of challenge ourselves to go outside of our comfort zone to do that. So I am pleased to present our next presenter from Oklahoma. He had the very challenging task of supervising me for 2 years in their internship and fellowship program, and he's lived to tell about it. It was an honor working with him. I learned a lot from him. I'm glad to hear and learn more from him today. Dr. Stephen Gillespie completed his graduate training in clinical psychology at Oklahoma State University, his clinical internship at the University of Oklahoma Health Sciences Center, and a postdoctoral fellowship in primary care and health psychology at the University of Oklahoma Health Sciences Center. Dr. Gillespie is currently a licensed psychologist and associate professor of pediatrics at the University of Oklahoma Health Sciences Center. He is a clinical associate professor and the Pediatric Psychology Emphasis Director for the Clinical Psychology Internship Program and Postdoctoral Fellowship Program. He serves as the Director of Research of the section of General and Community Pediatrics, where pediatric obesity is one of the research emphasis areas. He is also the co-director of the Healthy Futures Pediatric Weight Management Clinic. Please help me welcome Dr. Stephen Gillespie.
Well, thank you so much. And like Dr. Thornberry said, I've just recovered. You know, he's been out of our program for a couple of years. I'm just starting to kind of bounce back. No, it was a pleasure. You know, when I have to call him Dr. Thornberry now. I used to just call him Tim, but he's a doctor. When he came into our program, he was great to begin with. We learned a lot from having him in our program. And it's great to see that some of his training that he has continued on. He did a unique fellowship where he got to work at our state health department. And so I think Dr. Thornberry's come with this nice combination of he's got this public health approach, he's got the psychology approach, now he's coming back and partnering with you. And so it's great for us to see that. So we're happy to be here. Let's get started. So one of the things, let me give you a little background. Of course, no disclosures, imagine that. Motivational interviewing is something that I do quite a bit of. Tim focused on the fact that I do a lot of obesity work. My other hat, and it's great to hear some of the kind of common connections. Dr. Bowling and others have talked about some of the connections between obesity work and tobacco work from a public health standpoint. And so that's the other main hat I wear. So in our state, I manage our state tobacco helpline. And so I do lots of trainings about how do you intervene briefly about tobacco and how to use motivational interviewing. In fact, just yesterday, I presented in Tulsa to a group on MI for tobacco. So I think there's lots of similarities, and I do a lot of MI training. And so one of the things I want to kind of tell you today what you're going to get is really kind of an overview. So I don't expect anyone to kind of walk out of here as being kind of the MI, ninja and be able to, use the mojo on everybody that they see, but hopefully it'll kind of whet your appetite a little bit, but you'll probably walk away with some skills that you can implement. The other thing, just to kind of let you know, kind of my perspective is, and I do this training for tobacco as well as obesity, I'm really about brief interventions. I really try not to do kind of pie in the sky, we're going to talk to somebody for, 20 minutes. When I talk about doing MI, we talk about, 3 to 5 minutes. I think for most of us, and again, this is just like for tobacco, most of the time that discussion about BMI and making some of those changes, that's a tack on. For most of us, our families don't present to us saying, I want to talk about BMI today. Can you give me some tips? Just like they don't present to your office and say, hey, I'm a smoker. Can we talk about that? Usually we screen for it now because we have good guidelines. We screen for it, and it's our obligation to have that discussion. So if you think about it that way, typically these discussions are kind of a tack on. It's at the end of your normal intervention. So let's talk a little bit about practice gaps. MI techniques are recommended for pediatric obesity. Well, you guys have already kind of heard some of that from Dr. Whedon's presentation. Most clinicians are not very familiar with it. I think that is changing a little bit. Now we see more and more with some of our graduate training programs, whether it be for nurses, for dietitians and things like that, more and more some MIs being built into that training. So hopefully that's going to continue to change. Even those that have been exposed to MI, most of them don't feel too confident in utilizing those techniques. And I think we can all agree, if you don't feel confident in your techniques, chances are you're not going to use them much. Or if you do use them and you're not confident, how's that come across? Your patients can kind of feel that, right? If you're not confident in what you're selling, they're going to pick up on that. So again, we have some practice gaps. So our objectives for today, my goal is for you to learn some basic principles of MI, to understand the role of MI techniques in addressing pediatric obesity, and to understand, let me stop right there. We talked about MI for obesity. And MI is a good evidence-based intervention, but I'm doing 2 talks today. I'm going to talk about MI, and then my later talk is going to be about goal setting. And I will really tell you, MI in itself is an approach. I don't think of MI as a treatment. I don't think MI is not magic. I think of MI as the door, foot in the door. So the MI is how you start the conversation, but you have to close that conversation. You have to be able to do some goal settings. You can get someone very motivated for change, but if you don't deliver, it's all for nothing. Okay, so hopefully that'll come across. And I think the nice thing about today, at least so far, it seems like all the talks have kind of built on each other. And so you get this kind of same message from a couple different perspectives, but over time, which I think is great. So why motivational interviewing? Because I want you to know that there's a good evidence base. It's not just something that, hey, Gillespie thinks is cool and he gets to travel around and present on. That's not a bad perk, though. I like that. I've enjoyed my time in Kentucky. But we have a good evidence base. We have got hundreds of randomized trials. We have several meta-analyses that basically show you that MI is better than treatment as usual. And when we talk about behavior change, typically, so if you're talking about tobacco, you're talking about increasing physical activity, making dietary changes, typically our treatment as usual has been direct advice or education. Because most of us, no matter what our training is, we all feel like we're educators, right? And when in doubt, we fall back into that education role. We tend to kind of fall back into the default where if someone's not doing what I want them to do, they need more education, right? And we do that again. I think it's a great analogy or a great comparison between tobacco. I mean, most of our providers would rather talk about the evils of tobacco than how you might try to get someone to change. And I think for obesity, we tend to do the same thing. We tend to preach to people about, all these things that you're doing, how bad they are for your health. I think someone else, several people have mentioned, most people realize they probably have some health issues. So again, what MI has shown is that those interventions are better than treatment as usual, okay? Most of that has come out, and again, it's come out when we think of all of our randomized trials. We have some of that for tobacco. We have some of that for physical activity. You can see the importance of MI now because it's starting to be built into our practice guidelines. It's built into our tobacco guidelines. It's built into alcohol guidelines. And now, just to kind of tack on to our other presenters, now we see it built into our pediatric obesity guidelines for how to intervene, okay? So if you think about that, if you think about MI as some skills kind of for your tool belt, it's great for tobacco, it's great for obesity, it's great for alcohol, drug and alcohol. If we think about some of the leading behavioral issues that our country struggles with, those are up there. So MI is a great skill set to have. When we focus specifically on pediatric obesity, again, just some evidence that, and again, we have this growing body of evidence that shows that MI in primary care settings can be effective at making some changes in regards to pediatric obesity. Specifically, this last one, this 2015 article that was published in Pediatrics, and I want to spend a little bit of time on this. Basically, they did a randomized trial. They had a treatment as usual group, and this was done in the Pediatric Research Network. So it was all with pediatric patients between the ages of 2 and 8. There were 3 arms to the study. So you had a treatment as usual group. You had a group of pediatricians that were trained in MI. And then you had another group where you had pediatricians that were trained in MI as well as dietitians that were trained. And I will tell you, they weren't just trained in MI, but they were trained in MI and behavioral interventions. Because again, it's key. You can't just motivate people. You have to deliver once you get people motivated. And the difference was you had treatment as usual. The group that just had the pediatricians, the goal was they were supposed to have, over a 2-year period, supposed to have 4 sessions devoted to using MI and those behavioral interventions. And it was suggested that they have 3 of those in the first year and then kind of 1 booster in year 2. Because again, what they really wanted to measure is, at 2 years, do those interventions make a difference? And the same thing in that third group, you had the pediatrician, same thing, supposed to do 4 interventions, and then the dietitian was supposed to do 6 over the course of 2 years. And again, the idea was to load most of those in the first year. And what they saw at 2-year follow-up was that that group that got both the intervention from the pediatricians as well as the RDs had decreased BMI compared to the treatment as usual. So that's one of the first studies that has really kind of shown, because we've seen where some MI and some behavioral interventions can do some, you can have some immediate outcomes, but that's the first one really to kind of show that at 2 years, a reduction in BMI. And I would even say, from my perspective, even that's the wrong measuring stick. Because everything you've heard today is, for most of us, we realize that reducing BMI is probably not what we're shooting for. For a lot of our kids, especially 2 to 8, we're just looking to stabilize. So I think this, even though it's a small study, I think we have more and more evidence to show that these brief behavioral interventions using MI can be effective. How's that sound? Have I sold everybody? All right. So the other thing, and I have to say, I'm a clinical psychologist, so I love to talk, but I love to interact. So, and I know everyone's tired. Everyone had, we weren't keeping track of who all had the paydays over there after lunch. But I like for it to be interactive. So if you have questions, and we're going to get to points where I'm going to ask people for feedback, but we're going to get a little bit of interaction going. So here, when we talk about behavior change, and again, Dr. Whedon mentioned this, the stages of change, which I think is very important. And she gave some definitions, and I kind of like to put my own spin on things. I think one of the most important things to think about with stages of change is it's not a nice linear process. People bounce around in those stages. Okay, so again, this kind of links MI back to goal setting. You may have someone in your office, whether you're a dietitian, family practice doc, they may be very well motivated. You may have convinced them, they may have come in ready to make some changes. You talk with them, you set some goals, and then what happens? They go back home, they got to take care of the kids, they got to do all this kind of stuff. And so our motivation, our stage fluctuates quite a bit. People bounce around in those. It's great now that everyone is so focused on stage of change, but it kind of worries me because I see in patient charts, Mrs. Jones is in the contemplation stage of change. She was in that stage that day at that given time. She may be at a very different place. So you really need to think of stages of change as a state, not a trait. You guys all remember the difference between states and traits? Traits is something that's part of your personality. That state, it fluctuates. So we bounce around. So I think of pre-contemplation, just like Dr. Whedon said, where it's not even on your radar. Okay, and we see this in tobacco, you don't see that, but we see this in pediatric obesity, where literally when you give them feedback about their BMI, sometimes those parents have no idea that it's a concern. They have no, because all they've heard is, oh, they'll grow out of it, and things like that. So I think of pre-contemplation where it's not even on the radar. They don't even think there's an issue with that. I think of contemplation. Contemplation is the yes, but stage. That is where the majority of us live for any kind of health behavior change. Most of us, it's, yes, I know I need to get more exercise, but I'm a busy student and I got limited resources and it's a difficult time for me. So to me, that contemplation, that yes, but, that's where we live. That teeter-totter, where we're ambivalent about it. We got the kind of pros and cons. Preparation, that's when there's that recognition. They're starting to kind of get geared up for it. And then again, just like Dr. Whedon said, you got action and maintenance. And I put in relapse. Because a lot of times you look at the models, and stages of change really came out of looking at drug and alcohol studies and how people make successful changes. And that relapse is important because people are going to kind of fall off. It's important for them to kind of get back and be re-engaged. Just like Dr. Whedon said, our goal is to match the intervention to the stage of change for where they're at that day. So if you're in pre-contemplation, if a family comes in and they're in pre-contemplation, if you give them, it's kind of like if a diabetic walks in and has no idea that they're diabetic, if you give them medications, chances are they're not going to take them because it's not even on their radar, okay? So you have to think about your goals. If they're in pre-contemplation, your goal, just like Dr. Whedon said, is to get it there, to have that discussion, to open it up, and hopefully open up the opportunity to do some education. If there's not kind of problem recognition, you giving a nice intervention is probably going to be failed. You're not going to get much uptake. Again, I think most of our work really happens with contemplation. We're those folks that yes, but stage. Yes, I've had some concerns, but I think it's important, but my spouse at home, they come from a different family, and it's always been that way. So that's where the rub is. So we talk about kind of stages of change. Let's talk a little bit about why people don't change. If we think about on the left-hand side, we think about the way I kind of boil it down. I grew up in Arkansas, so I'm just a simple country kid. And I like to think of things pretty in its basic form. So I think if we think about on the left-hand side, just the way we're wired, what keeps us from making some changes, procrastination, just to start with. All of us, in our best, in all of our glory, if you guys decide today, I need to make some changes, the vast majority of you would say, but it's Saturday, I like to start my changes on Monday with the start of the work week, right? I mean, that's the way we are. So even when we say, yes, it's important, we like to put things off. But it's easier if I do that the first of the month. I like to start my changes the first of the month. So we're just the way we're wired, we procrastinate. Behavioral economics. And that's just a fancy way of saying we would rather have a little bit of gratification today than the possibility of long-term benefit. Okay? And I'm going to give you some examples. And again, trying to make this connection between some of the work we do with tobacco. A lot of the billboards now have changed for tobacco. They've changed from trying to scare people to quit to where now they say, if you quit using tobacco, within the next 30 seconds, here are the health benefits. Within 30 minutes, this is the benefits. Within a day, here are the benefits. All of that gets at trying to make the benefits real and tangible right now. Versus that old adage, if you quit smoking, it may prevent you from having cancer 20 years down the road. I think we've started down that same road when we started with obesity. Because we would say, you need to eat this way so you don't get diabetes way down the line. I can tell you, we don't have that conversation anymore because our kids, they already, and again, I'm a psychologist, they already have funky labs at age 3 when they come in. This gets back to why it's important to do labs. You do labs not because you're going to prescribe a medication. You do labs so you can have that conversation to say, this is how it's affecting your child today. Behavioral economics. Don't make it about down the road. Make it about right now. And that's a switch for a lot of physicians, because a lot of physicians, I'm not going to do labs if it's not going to change the way I prescribe a med. Okay, you do labs to have a conversation. Behavioral economics, you got to say, look, it's affecting your health right now. The same thing when you start to make some of those changes, you're going to have immediate benefits. Okay, and that's the other things you have to talk about. I think with pediatric obesity is if you just look at BMI change. That's not where it's at. We're really big at preaching. We're more interested in what's going on inside. So lab values and things like that. It's not about weight. Avoidance, we typically avoid things that are difficult, right? I think one of the things we have to think about with a lot of our families, and again, I think about a lot of what drives what our families, how they eat and their physical activity, it's cultural. And when I think culture, it's big picture culture. I'm not talking about race, ethnicity. I'm talking about, I cook this way because that's how my mom cooked. That's how my grandmother cooked. That's the environment I was raised in. I think about family values. So again, it's hard to change those things. I think a lot of times we lose track of that. We think, oh, they should cook this way. They should do that. If you're going against kind of 30 years of history, that's really difficult to do. Okay, so we avoid things that are difficult for us. Habit driven. Let me ask you this. Here's my cheesy example. Do I have any coffee drinkers here in the morning? This morning, okay? First thing you get up, you drink coffee? Right. Let me ask you. When you get up, probably you don't have this, but you probably don't get up and you have this big philosophical discussion about, what should I drink today? Should I drink coffee, or should I drink water, or should I drink orange juice? Is that how it goes for you? No, you drink coffee because you drank coffee yesterday and the day before, and it's a habit. It's not a conscious decision. Same thing goes for a lot of our dietary decisions, okay? We're habit driven. The best predictor of your behavior tomorrow is your behavior today and yesterday, okay? So just the way we're wired, it's hard to break those patterns, okay? Bias toward a downward comparison. We as individuals, when we're faced with information, okay, we all like to think, I'm a good person, I take my health serious, I make good decisions, right? I mean, our kind of sense of self, that's how we view ourselves. When we're faced with information that runs counter to that, we kind of like to deflect it certain ways. And one of the best ways, one of the most effective ways that we have is we can always identify someone that's worse, right? Someone could say, hey, Gillespie, you need to exercise, you need to shed some pounds, and a typical reaction would be, I agree with you, I know I need to, but my brother, Doc, you really need to talk to my brother, right? I know I'm bad, but there's someone worse off. We have a tendency to kind of deflect those kind of things, okay, that bias toward downward comparison. We think about some other things when we're approached with information, reactance, okay? People think that only adolescents react. That only adolescents, sometimes when we talk to them and tell them they have to do something, that they kind of get defensive. But most of us, if someone comes to you and tells you, you have to do something, you have to make this change, you have to make that change, what usually happens? Do you say, I'm an intelligent adult, someone told me I have to do something, I'm going to go and enact that tomorrow? No. Most of us, when we're told, when we don't have control, when someone tries to take our control away and says, you have to do something, we do the adolescent thing where we feel like we're boxed into a corner and we get defensive. And when it comes to health behavior, even when we know in our heart of hearts we should make those changes, if we feel like it's being dictated to us, we will resist. We all have a little passive-aggressive streak in us, and we will resist. So you have to think about that when it comes to pediatric obesity. When you're demanding folks to make changes, you'll get that resistance. Reject labels. I think someone else had mentioned this before. Labels like, you're obese and things like that. That tends to have a pretty negative reaction from folks. Negative affect when you're dealing with this issues. Everyone's already mentioned several times that even talking about weight management in kids is pretty sensitive. It can bring up some negative emotions. So we go through this just to kind of say that it's difficult for people to make changes. When we think about pediatric obesity, it's complicated on a whole other level because you're dealing with the identified patient and the family system, right? When you're dealing with adults, you're just dealing with one person, but we're dealing with family systems, so it's even more complicated. So let's talk a little bit about how people do change. So when we look at this on the far right, we have behavior change. And when I think about behavior change, I'm talking about long-term, sustained behavior change. I'm not talking about our New Year's Eve resolution where we say we're going to do something and it lasts for a couple days or a week. Because tendency is we take on big goals that we're not able to sustain. But when you get long-term, good, consistent behavior change, you typically get it because of two things. You get it from commitment, which is next to it, and intrinsic motivation. So commitment is when I decide personally that I'm going to engage in that change. And intrinsic motivation is just what it sounds. Intrinsic, that motivation comes from me. I've decided it's important for me. I've decided, and I've got my own list of what kind of pushed me over the edge, but it's important for me. I'm not doing it for an external thing. Okay, our first presenter used a little bit of different terminology, but she got the same thing, kind of internal motivation versus external motivation. So you get good behavior change when you get commitment from the person and you get intrinsic motivation. Does that make sense? Because that is fundamental to what we're after. And I have to tell a little story about does that make sense. So I was actually doing an MI talk at the University of Central Arkansas probably a couple of years ago. And my mother lives in the same town. And so she came and heard my talk. And so afterwards at lunch, I asked my mom, how did you think my talk went? And she said, I thought it was good, but do you know how many times you said, does that make sense? So even now, moms give me feedback. But it is critically important that you realize that if you really want someone to engage in behavior change, we've got to get commitment and intrinsic motivation. So how do you get commitment and intrinsic motivation? You get it through your interactions where you get increased change talk and decreased resistance. So you guys are like, what's increased change talk? When we do MI, we want to get the patient or the parents, we want to get our target individuals, we want to get them talking about change. We don't want them nodding their head to our suggestions. We want them to talk about change, why it's important, why they want to do that. So we want to get them talking more about change, and we want to decrease resistance. And by resistance, that's that old adage where, if you see someone with a problem, you got to confront them. You got to hit them head on. In MI, we don't do that. In MI, we're going to collaborate with people. In MI, we want to partner with people. We want to be collaborative. So when we feel resistance, we're going to step back and go a different direction. So that all sounds great, but how do you get it? You get that through the style and spirit and very specific skills and strategies of MI. So what is this great thing called MI? It's a client-centered directive method for enhancing intrinsic motivation to change by exploring and resolving ambivalence. Remember we talked before about the stages of change, that contemplation, okay, that's where we're ambivalent, right? That's that teeter-totter. So it's really kind of built more for that contemplation stage. It's client-centered, and I'm sure all of us, any kind of healthcare provider, no matter what you're at, what level you're at, that's kind of the sexy word right now, right? Everything has to be client-centered, patient-centered, and what does that mean? It means you have to partner with your client, right? You're going to be collaborative with them. It's not going to be you talking down to them. You're supposed to meet them where they're at, and that's what MI is all about. It's a directive method, and this is a little bit different. If you go back about 20 years ago, MI, people would say, MI, it's that soft psychology stuff. You're just going to reflect, and you can be in there for hours. No, you can be directive. Okay, you can focus on goals. You can be directive. So in MI, we attempt to observe, respect, and avoid sustained talk. Okay, people that are stuck, we want change talk, not sustained talk. We want to elicit, amplify, and affirm that change talk. And then we're going to talk specifically about how we do that. The other thing I'm going to get at before we go too far is a lot of times I get questions about MI and are there any kind of pros and cons or things to think about when you use that as far as how culturally sensitive it is. Okay, and I think you always have to think about that. You have to think about your patient. You have to think about our other cultural considerations. And again, when I think of culture, I think family values, history, I think all that kind of thing. But just like Dr. Whedon said, we do a lot of work with a lot of our tribal groups in Oklahoma. And so this topic comes up quite a bit. I think MI is very culturally centered. Because what you're going to see as we go through this is MI is really about eliciting information from the patient, finding out their own values, finding out their own thoughts about change. So it's very individually based. And I think from that standpoint, it's less about me and it's all about them. So I think it's extremely culturally sensitive. With that said, though, you're going to run into some people that it's not a good fit for. Okay, so I always use the example of my father. He was a veteran, received all of his care at the VA, and he was old school. And by that I meant he looked at every type of medical professional like they walked on water. No questions asked. If a physician or dietitian, nurse said, "Hey, Dr. Gillespie or Mr. Gillespie, we're going to need you to run your head in that wall 5 times a day," he'd say, "Okay," because that was it. It was no questions. If you tell me I need to do something, I will do that. I think most of our population isn't that way anymore. Most of our population, they read things on the internet, they investigate things, they're much more skeptical, but you do have to be careful. Okay, because MI, if you use MI on someone that is not a good fit, you're going to get funny looks. Okay. The other thing I always say is MI is for those folks that are ambivalent, where they're struggling to change. MI is not for people who walk in and say, "Hey, doc, give me the answer." If they come in and say, "You don't have to sell me, I know I need to change, tell me what to do," then what should you do? Tell them what to do. Because if they come in and they say, "Hey, what do I need to do?" and you go into reflection mode and say, "It sounds like maybe you're trying to ask me," they're going to look at you like you're a fool. Okay, so you use MI when you need to. You don't always have to walk around with your MI hat on. You use it when it's needed. And I think that's terribly important because some of the things we're going to talk about with MI, you're going to think if I do this all the time, it's going to slow me down. It's not going to be productive. So you take out your MI skills when you need it. I got to think about my mom. Does that make sense? Because that's fundamental. We're doing brief interventions. No one's asking you to be the MI king or queen all day long. Cool with that? All right. So let's think about, style and spirit of MI. It's relentlessly, radically patient-centered. And again, I tell people that if you're going to do good MI, you have to be genuinely, honestly interested in your patients. How your patients tick. What they like, what they don't like, what their thoughts are. You really have to be inquisitive. And so to do MI, it will wear you out because you have to be a good listener. Because you have to do less talking and more listening. And when you do respond, it's got to be strategic. So you have to really want to know what makes people tick. If people don't want to change, that's all right. But you got to figure out, you got to ask them some questions so they can give you some information. That shouldn't irritate you. That should make you curious. So you really have to be curious. So it's really, really radically patient-centered. It's a way of being with people characterized by 5 fundamental principles. And I want you to think about these. So later on, we're going to talk about very specific MI skills, but you should always think about, from an MI perspective, do whatever I'm doing, does it map back on to these 5 fundamental principles? First fundamental principle is collaboration. Collaborative versus a one-up or authoritarian relationship. So MI, you think about the old days, they talked about, are you in the big chair and the patient's in the small chair and you're talking down to them? We're on the same team. Okay, it's very collaborative. Let me ask you this. We are all content experts, right? So if you're a dietitian, you have expertise in dietitian, right? Who's the expert when it comes to your own behavior? The patient. So we have to think about the patient is the expert. Or when we think about pediatric obesity, the patient and the family, they're the expert on their own behavior change. We're the content experts, but they're the expert on their own behavior. And let me ask you this. Does anybody in this room, do we have any power? Does anybody have the power to actually make somebody else change? Yeah, we only have control of ourselves. So we can't even though we know in our heart of hearts they need to make that change, we can't force anyone to make that change. We don't have any magical powers. We don't have any silver bullets. We can't do that. So it's important for us to realize that at the end of the day, I can't make someone change. I can ask them good questions. I can try to kind of lead them that way, but at the end of the day, it's going to be up to them. I think we can all kind of intellectualize and think that, but we still get frustrated, right? We still walk out of rooms thinking we failed because we couldn't get them to move along. So thinking about MI, you have to be able to accept the fact that at the end of the day, it's up to them. You can set the stage, you can try your best interventions, but it's not always going to happen. The other thing is I think with MI, I'm big on how we measure success. We tend to think of success, so if I want them to engage in more physical activity, make a dietary change, we tend to think if they don't agree to do that tomorrow, I failed. I think the beauty about MI, this kind of gets back to some of the other talks, more of a public health approach. MI is not just about that interaction today. It's about setting the stage for all the future appointments that they're going to have. So my goal is not only to try to get them to change today, but my goal is to set the stage for the next provider. How many of you have walked into a clinical situation and you felt like it's less about you? If you feel that resistance, if you feel that attitude, it's less about you, but it's about the fact that they've had some negative interactions with other health providers. They're already defensive. Is that just me? Has that happened to other people? Okay? I think it happens all the time. So if we're thinking about pediatric obesity and we're thinking about the idea of making small changes, lifestyle changes, things people can continue to do, we have to be willing to think about making those small changes, and if they're not ready for it, setting the stage for the next provider. I want to make sure at the end of that clinical encounter, I don't spoil it for the next person. Because when we think about our guidelines about screening for obesity, giving feedback, more and more, we should all be doing that. Okay? It's kind of like with tobacco. It's not just one person asking about it. There should be multiple opportunities to have these discussions. So you want to set the stage. So you have to think it from a public health perspective to have those nice, brief, effective conversations. Am I on the same page? Or is that crazy talk? Everybody cool with that? You guys are so excited. It's awesome. It's like, okay. All right. It's after lunch. It's a big salad. I realize. So we talked about the first one as being collaborative. The second one is being evocative. Okay, being evocative versus imparting or inserting knowledge. We have expertise, but we want to be evocative. And by that, we want to get the patient talking more than us. We want to evoke from them what are their reasons for change? What are their barriers? What's their motivation? Because most of the time, you know what we do when we give people suggestions or we think, oh, it may be this or maybe that, we're just guessing, right? We're looking back on all the other patients we've encountered. We're making our best educated guess. So most of what I would say with MI is let's not guess, let's ask. Let's ask them what motivates them. Let's ask them, what have you tried in the past? What do you think the barriers are? How do you think you might have success? We want to evoke from them. The next one is autonomy supportive versus controlling. And this kind of gets back to we don't have the power, we can't make anyone change. So in MI, we're going to do lots of cheesy things to be very explicit about that. We're going to say, nobody can make this decision for you, it's really up to you. I can give you some information, but it's really up to you with what you do with it. We're going to make it explicit that they're the driver, okay? I can offer some suggestions, I can kind of help, but it's up to you. We're going to make it explicit they are in control. And I will tell you, and this is unfortunate, I think, in our healthcare system, if you do some of that stuff, you're going to get some immediate buy-in. Just because they're so used to people telling them what to do, they're going to think, you're the first person that's told me that I don't have to do that it's up to me. And you may have more buy-in just because of that. And that's a sad fact, but that will happen. The next one, direction. You want to be directive versus being avoidant or distracted. Okay, so you're on the target. Target behaviors, target goals. The last one, being empathetic, empathy, versus being dismissive or disrespectful. We had that slide up there. It's hard to change behaviors, okay? Especially when, it may be going on for multiple generations and things like that. So we need to be empathetic to that. So we're going to use an MI. We're going to reflect a lot. We're going to try to connect with that emotion. But we want to be as empathetic as possible. Because most people, like everyone said, most people realize they probably need to make some changes. It's not because they don't want to make those changes. A lot of times it's because they have some real struggles. We need to acknowledge that. So those are the 5 kind of global principles of MI that I want you to kind of hold on to and think about. When you think about your interactions or other people's interactions, how do those behaviors map onto those 5 fundamentals? Okay? But we're also going to talk about some micro skills. We're going to talk about very prescribed behaviors. So some of these are going to be seeking permission to add a target behavior to the agenda, evocative questioning, empathetic reflective listening, and some other MI consistent behaviors. So seeking permission. So in MI, we're really big on asking permission. Asking permission, is it okay if we spend a few minutes today talking about, Johnny's diet and how it might be affecting his health? Okay? The other reason why we're big on this, because one is, if you ask permission, they said, sure, that's why I'm here, you're the doctor, you're the nurse, sure, I want to hear about things that might be affecting their health. Everything that comes after that, they've asked for. It gets back to that sense of autonomy and control. The other thing, we've all agreed that a lot of times these conversations come tacked on to a visit. They didn't come here they didn't show up with the idea, I'm going to talk about my kid's BMI today. So you're adding something to the agenda. You're going to catch them off guard. So again, another reason to ask permission. Now, I always get a little bit of pushback and they say, oh my God, what if they say no? And I say, if you pitch it the right way, 99.9% of the time, they're not going to say no. If you make it about the kid's health, they're going to say, sure, that's why I'm here. If you say, is it okay if we spend a couple of minutes talking about, why Johnny might be obese? You're going to get some pushback. Or if you just say about weight. If you say dietary, physical activity, about health, I can almost guarantee you they're going to say sure. Okay, so it's how you say it. You got to be a little strategic in that, but ask permission. Again, and we've got some examples of that. And the other thing, just to kind of tie back into that, another way to say it is, do you mind if we spend a few minutes today talking about your child's BMI and how it relates to their health? Because again, BMI is something that's our measuring stick. And so I think we can't avoid talking about it because they're going to see it in their records and things like that. But again, if you always link it to health, you'll have no problems. Evocative questioning. we tend in MI, we want to use more open-ended questions than closed-ended questions. Now, when I say that, a lot of times people think I'm saying you shouldn't ask closed-ended questions or anything like that. I'm not saying one's better than the other, but when you kind of go into MI mode, we want to ask more open than closed. And because we want to be evocative, we want to get them talking. Closed-ended questions, you get very little information and it's very specific. Open-ended questions, you don't know where it might go. You're going to get all kinds of information. So when you're in MI mode, you want to ask more open-ended than closed-ended questions. Another MI skill that we use quite a bit is the scaled questions. Okay, so a lot of times what we'll do is we'll ask about scaled questions. And so kind of 3 different ways we'll do this. So typically we'll ask on a 1 to 10 scale, with 1 being not at all, 10 being kind of maxed out, how, and we can ask it 3 different ways. We could ask about readiness, importance, or confidence. So again, when you ask this question, you might say on a scale of 1 to 10, how ready is it for you to make some changes in increasing your kids' physical activity? Okay, and that would focus towards a parent. Or if you're talking with an adolescent, on a scale of 1 to 10, how important do you think it is to make some changes to how often you eat out? Okay, you got to be specific about it. Now, I will tell you that there's no magic in just asking that question. Okay, the magic is whatever number they give you, how you're going to follow that up. So let me give you an example. So if I say on a scale of 1 to 10, 1 being not at all, 10 being maxed out, how important is it for you to make some dietary changes? And you say, it's about a 5. So my good MI hat on, I would reflect that back and say, okay, I hear you. You say a 5, that's kind of middle of the road. You know, I got you. But let me ask you, you say a 5, why are you a 5 and not a 1? So when you pose that question, then they're going to tell you why it's important. Because a 5 is middle of the road. But if you say, why a 5 and not a 1, they're going to tell you why it's important, what's getting them, motivated. That's going to open them up. And that, what they give you there, that's change talk. They're going to talk to you about why for them, personally, is it important. You can guess all day long, right? And mostly that's what we do. We guess about what's your motivation and things like that. And MI, we want to open them up and get them to tell us. So that trick where you say, it's a 5, tell me why a 5 and not a 1. Does that make sense? If you just get a number, if you just ask that question, they give you a 5 and you move on, it's a wasted intervention. The goal in that is you got to follow it up. Now, a lot of times people will follow it up both ways. They'll say, okay, you're a 5, why a 5 and not a 10? And they'll give you barriers, why it's difficult and things like that, which again is good information. You want to know as much of that as possible. If you follow up both sides, you always want to end with change talk, right? Just like if you kind of sit down with someone and do kind of pros and cons, but you're wanting to move them in a certain direction, you want to end that conversation with going in the direction you want. So the other question a lot of times people will give me is, if you ask a scale question on a scale of 1 to 10, what if they say I'm a 0? Okay, on a scale of 1 to 10, they say I'm a 0. People say, oh, I'm dead in the water, I don't know what to do. No, you're not, okay? Again, with your good MI hat on, you'd reflect that back and say, I hear you, it's a 0, sounds like it's not even on your radar. I totally respect that, but let me ask you, what would it take to raise that 0 to a 3 or a 4? And what they're going to give you is they're going to give you change talk. They'll tell you what would have to happen, what it would have to look like, what would have to change in their environment for things to move them up. And that's our goal. Our goal is to get them to engage in that change talk. Okay? So again, a lot of times you can ask it about importance, readiness, confidence. Some people will ask about all 3. I typically ask about 1. Okay? I will ask just about one of those areas. Because again, most of what I do is brief interventions. I don't have time to ask about all 3 and explore it both ways. The other thing that's really critical and important to think about, on here we talk about readiness, importance, and confidence. Readiness, to me, I think readiness is the combination of importance and confidence. Okay? Because let me ask you, a lot of us, and a lot of the families you will run into, they will think making changes is fairly important. The problem is they're not very confident they can do that. And when you're not very confident, your readiness goes down. Most of us as healthcare providers, if someone's not doing what we want them to do, we think either they're not educated about it or they don't think it's important. And a lot of times it's neither one of those. It's more about confidence. Maybe they felt like they failed before. Maybe they felt like, well, that's how my family was, and the deck is stacked against me. Okay? So you have to use your own kind of clinical intuition and know kind of how the environment's going, how the discussion's going, to figure out, do I want to ask about confidence, importance, or readiness? But you really need to think a lot of times people aren't ready to engage in change. It's not because it's not important to them. It's because they're confident. And if they're not confident about it, whatever intervention you're selling that day, they're not going to be too willing to take it up. So again, this using a scale question and following it up, that is a fundamental MI. I tell people for brief interventions, I want you to do just a couple things, because I think you really have to boil it down to kind of behavioral nuts and bolts. And using a scale question is one of those. I tell people, if you ask permission, you ask a couple opening questions, use a scale question, you reflect a few times and summarize. If you do those things, good MI will follow. Okay, and we're going to talk about some of these others, and we'll kind of wrap up and talk about that in a minute. Questions about using the scale question. If you follow it up, good things will come out of it, I promise you. So let's talk just a little bit about reflections. So one of the things with reflections, we're going to talk about kind of simple reflections, complex reflections. That using reflections, that's kind of a hallmark of that's a good MI skill. But I think one of the ways I think about the role of reflections is to test your hypothesis, a hypothesis testing mechanism. We tend to think, I think we tend to kind of devalue or underestimate just how complex our communication is. If we think about it, I say something, it's the words that come out of my mouth, it's what comes through your hearing, then you add meaning to it, and then you respond. So there's lots of times that we have miscommunication. How many people have been in a clinical interaction with somebody, you thought you've had a good encounter, they nodded their head the whole time, you're getting ready, you're kind of stepping back, you got your hand on the doorknob to leave the exam room, and they say something and you realize you were on two different wavelengths. Has that ever happened, or is that just me that's a bad communicator? Has that ever happened? Where you're leaving, you're like, oh, I got to go back and redo everything that we just talked about. Has that ever happened? Okay. So one of the things I think we don't do enough is periodically through our encounters to reflect back as a way just to kind of test to make sure we're on the same page. So you can use reflections to kind of to test your hypothesis about what you think the patient's feeling, the family's feeling. So I would encourage you to reflect and summarize to make sure that you're on the same page. Okay, now some of the feedback I get, people always ask me, do my reflections have to be accurate? And I say, oh my goodness, no. Because if you reflect back and it's inaccurate, what's that patient or family going to do? And what are they going to do? They're going to give you more information, right? So I'm even a firm believer in sometimes strategically, I will reflect back inaccurately to open them up. Okay? Because the nice thing is if they correct you, they're going to open up and give you more information. So I would encourage people with reflections to experiment a little bit. A good reflection, sometimes what we look for, because we're going to talk about this, but you can have simple reflections where you're just kind of parroting back what you heard them say. It demonstrates that you understand what they've just said. More complex reflections where you want to reflect back kind of the meaning, the emotion. Or I think if you can reflect back really what hasn't been said, but really what's going on with somebody, that's when you connect with people. When you can give a good, accurate reflection and they go, I haven't said that, but that's what I mean. They get me. I think that's very important. So I encourage you, good MI uses reflections quite a bit. And you can use reflections just to let them know to be empathetic, but also test your hypothesis. Maybe they've said one thing, but you've kind of got a working hypothesis about what you think's going on with that patient or family. Throw it out there. Reflect that back and let's see what it is. Because they may say, gosh, you really get me. Or they're going to say, no, that's not really it, but it is. And they're going to give you insight into them. And that's what you want. You want to be evocative. You want to get them talking. Again, we talk about simple reflections. Again, in reflections, really, if you think about those 5 fundamental principles of MI, good reflections will come across and it'll be that you're collaborative, you're empathetic, autonomy supportive, it hits all of them. So we want to use reflections as much as possible. Some other MI consistent behaviors. You can ask, you can advise and educate, but do it with permission. Okay? You have to fight that impulse. We always want to advise and educate, but do it with permission. And again, I think we have to be realistic. We all know that there are going to be times when it's built into our guidelines, it's built into our job descriptions. I have to relay some information to you. Okay? So people always say, well, what if they say no? Then I can't do what I'm supposed to do. Okay? You can couch it where you can say, you can also give them information and give them permission to disregard. You can say, look, I understand you don't want to have a lengthy discussion about this, but as your healthcare provider, I have to let you know that these are important to your health. Now, what you do with that information is up to you because you're completely in control, but I got to share this with you. Even that changes it to where you do your job, but you let them know you're in control. That people will be much more receptive to that. Some of these things sound so different. They sound so simple, but they can make a huge impact on how people receive that information. So again, it's okay to advise and educate, but do it with permission. And you've got examples of how you can do this. Another one is we want to collaborate on potential solutions or plans. We know that for all the things we're trying to work on, making dietary changes, increasing physical activity, there's not kind of one golden rule to do that. Okay, so at MI, we want to try to come up with a menu of options. Again, we want to be collaborative. We don't want to be the drivers in that. We want to get their ideas. A lot of times families are going to have good ideas of what kind of changes they might be able to implement. Another really important thing is we want to affirm and support the patient and family. I think in one or two of the other talks, people talked about self-efficacy, right? So we want to build our patients up as much as we can. Okay, because if we're going to ask them to do really difficult work, we're going to ask them to go home and change the way they eat and the way they purchase foods and all that kind of stuff. If we're going to ask them to engage in difficult behavior change, we want to get their confidence up as much as possible. So we want to reinforce good choices. We want to reinforce any kind of attempts they've made. And I got lots of cheesy sayings, but I will tell you, I think about it this way. You want to build them up as much as possible. The higher you can build them up, you're going to increase the odds that they're going to buy whatever you're selling that day. That's a cheesy way to say that, but I'm telling you it's true. If someone feels defeated and you're asking them to make tough behavior changes, how do you think that comes across? If people feel like they're struggling and you're asking them to do even more, so you got to build that self-efficacy up. If they feel more confident, the more confident they feel when they walk out that door, you increase the odds that they're going to actually go home and try to make those changes. So you want to build them up. Sometimes that can be difficult because sometimes we probably all feel like there have been times when you're struggling to find some ways to praise them. And I say praise them for all kinds of things. Praise them for coming in that day. Praise them for taking time to talk with you. Praise them, you could say, look, I know this has been a difficult conversation. I know you didn't expect to talk about this today. I really appreciate you taking the time. Thanks so much. Find some ways to build up your patients and families. Again, you always want to emphasize choice and autonomy and control. And again, we're going to be explicit about it. We're going to say things like, it's up to you. Nobody can make this decision for you. You know yourself better than anybody. Okay? So we're going to say things like that to make it very explicit that it's up to you. They've got control. Some things we don't want to do. Confrontation. We want to avoid disagreeing, arguing, correcting, shaming, blaming, anything with ing. We're going to avoid that, okay? We're not going to fight with our patients and families. Now, we as providers sometimes get sucked into that. In MI, we call it the righting reflex, okay? Sometimes our patients and families will come in and they'll say, hey, I read this on the internet or this, and our first impulse is to educate, to tell them all the reasons why that's inaccurate. I tell people, if it's not absolutely critically central to your topic, let it go. You have to fight the impulse because you will spend limited time and resources on that. Going down that rabbit hole, you got to stay on target, okay? So we don't want to confront, we don't want to argue with our patients and families. I do a lot of training with our pediatric residents. We train them in MI, train them in how to get along with their patients and families, and it kills me, but sometimes I hear people talk about, and you guys got to let me know if you ever heard this, but I'll talk with a resident and they'll say, I've had that conversation with that patient and family and they just weren't getting it, and so, I had to come in and I had to have the come to Jesus talk with them. You guys ever heard that? Is that just an Oklahoma thing where people say, I had to go in and basically what that means is I had to go in and I had to set them down and I just had to tell them how it was. So that means all that MI stuff goes out the door, and basically I went in and told them what they had to do. So you guys don't have that in Kentucky? Have you ever heard of that where people, and I think a lot of times what it is the provider gets frustrated. They feel like they're not making any progress, and so they feel like, okay, I got to go in. And at the end of the day, I think those conversations, it makes the provider feel good because it makes them feel like they did something, but it doesn't have much effect on behavior. It's kind of like I'm going to go in and I'm going to scare them. I think typically for most people that doesn't result in much long-term behavior change. A few people, it may trigger them, get them thinking about something. It may trigger something, get that intrinsic motivation. But those kind of scare tactics for most people, I don't think is too effective. So you definitely don't want to do that. You don't want to advise without permission. Again, always ask permission. All right. So you guys saw this slide with Dr. Whedon, so we're just going to skip through it. Because what I want to do, we've got just a few minutes left. I want to get to, all right. So hopefully all of our technology works. I want to show a quick video clip. Now that you've we've talked about the 5 fundamental principles of MI, we've talked about some of those very specific skills. So if you think about specific skills, asking permission, using open-ended questions, reflecting and summarizing, asking a scaled question, and what's the most important thing? If you ask a scaled question, what do you have to do? Follow it up. If you don't follow it up, don't even ask. Because my 5 is different than your 5 and her 5. A number doesn't mean anything without context. And the patient has to give you the context. So let's watch this and then we'll have a little discussion about what you see, if it works. Hold on. All right, so a fairly brief intervention. I think that, I think it's right at maybe 5 minutes, something like that. But thoughts, what did you see from an MI perspective? Besides, when I watch that, and I watch it so many times, all I see is my growing bald spot on the back of my head. So outside of my bald spot, and my Arkansas accent that you heard, what, in relations to MI techniques, what did you see?
Permission.
Ask permission?
She talked more than you did.
She talked more than I did? Okay, awesome. Okay.
You refocused.
Okay, so pretty directive, kind of directing the session, refocused.
You were reflective.
Okay, so reflections,
Open-ended.
open-ended questions. And with the reflections, I actually did, we talk about being a compound reflection, where you reflect back. On the one hand, I hear you say this. On the other hand, kind of getting at that ambivalence. So the reflections, what else?
Scale question.
Scale question. And did I follow it up? Followed it up.
And confidence was her biggest.
Yeah. Yeah, I mean, so she knew, again, and one of the things is, so this was, we didn't script this out, so it was, it wasn't a real mom, it was a graduate student that, knew she was going to play this role, but we didn't script it out. So like when she asked the question about, so are you saying my daughter's fat? That was not scripted. But I think, one of the things it kind of shows is that she didn't come into session expecting to talk about that. But when it came up, she did have some concerns, but you kind of had to ask some questions to kind of dig it out of her, right? What else did you notice?
Empathy.
Empathy, very empathetic. Okay, and how? What did I do to kind of express that? Somebody already said it.
That's hard.
Yeah. Try to kind of get at that emotions, that struggle, right? Okay. What did you think about this? Because again, this is a little different approach where, I wasn't saying, okay, we have to do this. I mean, she kind of set the agenda. And I tried to strategically did some things to say, hey, it's not up to me, it's up to you. What did you think about that? Do you think it kind of flowed? Did you think, oh, that's just kind of, I can never see myself doing that? What are your thoughts? Go ahead, sir. I see you want to say it.
As someone that fits on the other side, I would be very uncomfortable with that.
Okay.
Just because I like to be told.
Right. And that kind of goes back to that
Yes, the other part.
Yeah, so for those folks who kind of come in and say, hey, look, you are the doc, tell me what to do, great. Yeah. And so I think in those situations, then if they say, tell me what to do, then you tell them what to do. if you kind of use all the reflection, things like that, it's going to be, that's kind of awkward. Yeah.
But very effective.
Right. And I think for all of us, we need to make sure we don't get into kind of boxes where we've got to be flexible and kind of react to our patients. But you're right, for some people, that's not going to be a good fit. What else? Yes, ma'am.
I had a situation where, and I brought this up in a meeting before, but where I was seeing a pediatric patient for another issue, and the child was very overweight. And so, out of concern for the child's health, I brought the topic up, but I did not ask for permission to talk about it.
Right.
So it ended up that I was reported as being rude and what have you. So I think that the ask permission, I think is a very important thing. I think that would definitely help. And I think that motivational interviewing is very necessary in dealing with pediatric obesity because, there's a lot of emotional impact.
Right.
When somebody hears that their child may not be healthy because they're overweight.
Right. So one of the things I was going to mention, I think all your comments are spot on. Sometimes when I show this video, people will make comments, well, I would have pushed for more physical activity. Or, instead of kind of one family outing, I would have done more than that. And again, I don't want to give away all my stuff in my next talk about goal setting, but, I want people to pick goals that they're going to be successful with. Because it doesn't do either one of us any good to pick a goal up here, and then when they come back in a month or whatever, that they're not going to be successful, right? But I think the problem with that is those small goals, when they come back in, their BMI is not going to change, right? And so that kind of gets back to we got to do a better job of getting on the same page as what's our measuring stick? Is our measuring stick going to be we're going to measure behavior change, which eventually is going to lead to better health outcomes? Because if we just use kind of weight reduction and BMI, we're all going to be disappointed, right? So we have to think about, because again, in adults, the only way to move that BMI is to lose weight. For kids, we talk about this all the time in our clinic. Our kids, we'll see kids, maybe the last appointment's in October, and then they'll come back in January, okay? And we always talk about, I always ask them, when you came in today, they weighed you, is anyone giving you feedback about your height and weight and BMI? Because even if no one's done it, I guarantee you moms look at the scale when they weigh the kid when they come in. It's this big elephant in the room, so let's talk about it. Because I want to know if BMI is the same, their weight's gone up, but BMI is the same, I want to know how they perceive that. Because if there's differences in how they perceive it and how I perceive it, we're operating on two different levels. So we use this example all the time. If someone, we see them in October, November, then we see them in January, and they've maintained, we're like jumping up and down, right? Because that means you've maintained through Thanksgiving holiday, you maintained through Christmas where you're out of school, there's nothing but food sitting around. I mean, to be the same a couple months like that is huge. But if you just look at it from a number standpoint, some people would say, see, nothing's going down. So that's where you kind of get back to the measuring stick and how you've got to get on the same page with patients and families about, how are we going to measure? We're going to measure behavior change. And we're big into saying, look, even if your weight and your BMI, you have no change whatsoever. If you eat better and you get more physical activity, your labs are going to show it. So again, I think you got to talk about that measuring stick. What are we measuring? Yes,
I
ma'am.
think sometimes just explaining what a BMI is. We throw BMI around. We're used to sharing it with our coworkers or other professionals, but parents come in, they don't know what a BMI is.
Yeah, they get confused too. Yeah, and that's, I think, the other thing sometimes I think when we can get really we could have a whole other discussion about this, but sometimes we as providers don't want to use certain terminology because how it may be interpreted or perceived. The only problem with that is if the rest of the world operated like that, it'd be okay. But nowadays, people get their records printed out. And so, they're going to see the definition of, a diagnosis of obesity or BMI of this. So even if we don't, even if we say, hey, I would prefer not to use that language, if we don't, our patients and families are going to be horribly confused because they're going to say, well, I went to this one specialist and they never mentioned that, and I go to somebody else and it doesn't take much. And I think we get desensitized because we live in that medical world, but it's horribly confusing to them. So I think sometimes even, again, some of the terminology that we would say it'd be better if everyone didn't do that. If other people are using that and they're getting copies of their medical records, I think it's kind of up to us to use that and try to put it in the right context and add the right definition to it. That's a little bit of one of my preachy things there, sorry. Other questions about the video clip? What would you like to have seen different? Lord knows I could do some things better.
You know,
Yes.
Steve, one thing that we talk about sometimes too, like on your double-sided reflection, sometimes finishing with doing the sustain talk first and the change talk second is sometimes helpful too.
Yeah, definitely, definitely. And that's kind of one of those things where you want to end in the direction you want to go, right? So, if you're going to do pros and cons of making a behavior change, you want to end with the pros. You want to lead them, to a certain degree, you want to be directive and kind of lead them that way. Yeah, very important, very important. Other questions or comments?
Do you ever, where it shows the growth chart, like you mentioned it?
Yep.
I didn't know if that was something.
Yes, so definitely. So again, most of our work is in a multidisciplinary weight management clinic. And so Dr. Whedon always goes over the growth chart with them. The only thing is in our clinic, at comprehensive visits, so when they come in our clinic, it's kind of it depends on how they're doing, depending on what providers they see. They always see our dietitian, they always see psychology. So they may not always see the medical provider. So I always ask about, did you get feedback on height and weight? And I have on my little notes, I always kind of document when they first came in with their initial height and weight and BMI, the last visit, and then today's visit. Because that's the other thing is that, we tend to kind of make comparisons back to the last visit, but we really need to put the comparison back into when was our first interaction, right? Because there's lots of fluctuations. So I don't always kind of show it to them visually, but I'm able to discuss it with them. Yeah. Because again, one of the things that Dr. Whedon said, for most of our families, I thought it was great because I was flashing back to clinic when Dr. Thornberry's with us. We always talk about, if you come into clinic, and we always use the example, we always do this. If your BMI and your weight have been going up like this, none of us have any magic and should expect that all of a sudden it goes like this with kids that are growing and developing and things. So, so we really emphasize that and have those discussions. Any other questions? I know we've got another, I think we're going to hand it back over to Dr. Whedon here in a minute. So, but what we're going to do in the afternoon though is we're going to try to then do a little bit of review about MI and then jump into goal setting because again, they're very much related and connected. Okay? All right, thank you so much.